don't focus on the fundamental, we will be splitting hair all the time and focusing on the bits of extra. It is as if we are adding some spices without taking care of the main ingredients. Can I have my slides, please? I can't entertain without slides. I try, okay? All right. So either it's saying we don't know about the fundamental, or we are unable to apply that knowledge, because we all know the fundamentals, and you don't need me to remind you about what are the main non-controversial issues as far as success of IVF is concerned. You know that the patient baseline phenotype, particularly age, is a major determinant. Giving the patient tons of add-ons when the patient is 44 is not going to make miracle. In actual fact, it is akin to doing a knee surgery when the problem is in the eye. Because this main problem for this patient is aneuploidy. And you are not going to correct it by 2 kilograms of vitamin D, or you are not going to correct it by giving her PRP. That is just not going to happen. The second one is hair ovarian reserve. If you don't have two eggs from a patient, your expectation should be proportionate and should be proportionately realistic. Because giving a patient where you end up with 2 eggs, one fertilizing and one C-cell embryo on day 2 or 5 embryo on day 3, if you give her again 2 kilograms of whatever add-on you like, it will not make any difference. It will just make her bankrupt. Nothing more, nothing less. Your ovarian stimulation. If you do your ovarian stimulation the right way, you probably are likely to help the patient much more than any add-ons. A patient who is entitled to produce 15 eggs should produce 15 eggs. But a patient who is not entitled to produce 15 eggs, if you give her again 2 kilograms of growth hormone, she will not get them, because the target audience is not there. So giving her growth hormone will not create follicles. It will again make her bankrupt, because it's so expensive and there is no evidence to support it and stand corrected. The method of fertilization, unfortunately, we have settled for an anomaly in this country, that everybody is having ICSI. When year on year, the data from the Society of Assisted Reproduction saying, when you do ICSI, when the sperm is jumping up and down, you are harming the patient chances. But that has just gone out of the window. Nobody really willing to listen to that. And if you don't have the right embryo culture condition in terms of quality control and the right concentration of oxygen and the right concentration of nitrogen and the right ingredients and the right medium, you can give the patient whatever add-on you believe in, whether it is endometrial scratch or embryo glue, or name it, it will not make a bit of a difference. And if you don't do your embryo transfer in a way that you feel comfortable with, a way that follows anatomy and follows physiology, whether you do it ultrasound guided or without ultrasound guidance, I promise you it doesn't make much difference. What it does is that you are comfortable with this position, you take into account the observation made going to the fundus and coming back, his recipe for disaster, all of these fundamental issues. If you don't pay attention to it, no add-on will redeem you. And the endometrium. If you pay attention to the endometrium and you feel that it is making the grade and it is adequately thick and there is no anomaly, there is nothing that you observe, then fine. But if you find something else and you give a blind eye, again, no add-ons will come to your rescue. And then resilience. Resilience is something that gets forgotten. Patients do not have unlimited funds to go through one cycle after another. So we should not make this worse by making them spend their money in unnecessary, unhelpful, unproven add-on. I was speaking to someone today who was telling me a cycle of IVF at one center in Cairo costs £75,000. If the patient is not a drug dealer, where would she get £75,000 from? And added, to add insult to injury, that said it wasn't all for the cycle. The treatment cycle was much less than that. But that 75 was accumulated on top of all the add-ons that were done. Because the patient had laparoscopy and had hysteroscopy and had that embryo glue and had that immune suppression, and you can name it. So it's important that this patient will not have the resilience to continue trying for IVF when most patients will need more than one cycle, just because we decided to give her a bit of spices. What does it say about us? It says that we have chosen to ignore the inconvenient truth about IVF. And the inconvenient truth, as inconvenient as it is a fact. On average, an IVF cycle is more likely not to result in a live birth than otherwise. Unless if someone correct me and say, in my program, I get more than 50% live births for all my population. It is possible. We have very clever people here. But it's not in my setting. It is not in American setting. The average for the country is 1 in 3. So if the average for the country is 1 in 3, it means 2 out of 3 will end up needing more cycles. So that is important to remember. The other thing is IVF fails more than patients think or expect. Even those who are well educated would expect really 60 or 70% chance of leaving the clinic with a baby. It's not a positive test. A positive test is not an outcome. A baby is. IVF requires resilience, as I mentioned. And that resilience is emotionally, physically, and financially. How do you help emotional resilience? By managing the expectation. Because if you promise the patient the heirs, because you made her spend all of her money on add-ons, she is certain to be disappointed, she is certain to be traumatized, and she will come out of the race that is IVF so early. The claims made about use of add-ons to improve success are exaggerated. And unfortunately, the literature doesn't help, because there are so many publications in thousands that they are not worth the paper written on. If we are not discerning, whenever we read a paper, particularly, I give you an example, for PRP, I can convince you that all what is written on PRP has only one place, the bin. Because it is not based on any evidence. It is based in evidence that I gave it to one patient and got pregnant. Exactly like صليت من غير وضوء ونفعت. Okay? I am stand to be challenged. Investing in preparation before treatment reduces the chances of failure. Because if you do thorough gynecological assessment and history and everything else not to miss a polyp or fibroid or adenomyosis, at least you will counsel the patient properly. And management of expectation is not always done well. احنا عندنا برضو ما تفولش. وتمنى خير. Okay? That doesn't help. You know that your patient here is 42, giving her 50% chance is misleading. And it's not true. Okay? If we do use add-ons, we really have not navigated good literature. We were struck by just rubbish literature, because if we navigated good and robust literature, we'll be reminded that in a decent clinic, say Boston IVF, which is known to apply good practice, they know what they do. Here is patient under the age of 35 who are supposed to be good prognosis patients. After 3 attempts, 2/3 of them will leave the clinic with a baby. 1/3 will need to try longer. And the chances are not 0 after that. The more chances they have, the more likely they will be closer to their end game. The same for patients who are 40 and above. After 3 attempts, 24% will leave the clinic with a baby. 75% will have to try again. And the chances are not 0. Still, they add to this. These patients will not be helped by any add-on you can think of. Again, you can challenge me. And this is what is not controversial. That if you happen to look at the chances of repeated cycle in relation to age, you will find that after few cycles, patients who have what it takes, younger patients with high rate of euploid embryos, probably most of them will leave the clinic with a baby with repeated attempt. But patients who are on this bracket, unfortunately, even with repeated, it may not mean that they will end up having a baby, because just biology is not on their side, and there is nothing you can do about biology when it's forbidden. What does it say about us using add-on? That we have become overwhelmed with what is on offer, and we can't ignore it. There is endometrial scratching, there is embryo glue, there is hysteroscopy unnecessary, there is all the weird and wonderful. I'm struggling to remember them because I don't use them, simply. Yeah. And here, as a reminder, look at the list. It could be endometrial scratching, endometrial receptivity assay, the ERA test, which I'm happy to take question on that. Checking natural killer cells, which, by the way, never killed anything or anybody. But put yourself in the patient place. When you say they are natural killer, the patient will pay her house. They will sell her house to pay you to kill those natural killers. Total and utterly unsubstantiated. You would like me, now or in future, show me any robust evidence in the literature to suggest that natural killer cell is helpful and it paid dividends in achieving higher success rate. And so on and so forth, because I don't have time. Giving the patient intralipid. You immediately assuming that she had high degree burn and you are giving her nutrition. She hasn't. She's just trying to become pregnant. All of that is made up. If you show me any paper show that intralipid makes any difference to the outcome, I'll be happy to eat the humble pie and go back on my word. Yeah. When you do a lot of stuff, embryoscope will not give the embryos additional powers. It might make life comfortable for the embryologist. If you can afford the money for this piece of kit, fine. But it will not give them any additional powers. Assisted hatching and embryo glue in particular are insulting to intelligence. Imagine if the embryo does not have what it takes to move from A to B to C in terms of division. Even if you stable it, it will go nowhere. So the fact that we are using embryo glue so that it doesn't fall down, insulting to intelligence, because the embryo is not a chandelier like this. The embryo is microscopic, about maybe 1/5 of a millimeter, if that. Yeah. And then all of the list that you have here in order not to waste time. How about tests? We did with NK cells and with ERA test, thrombophilia screen. It is very common. And all you need to do is go to any university hospital or general hospital and go to the antenatal ward. You will find a lot of patients there being admitted during their natural pregnancy because they have thrombophilia, meaning that their thrombophilia never stops them becoming pregnant. So why are we improvising by doing something that doesn't add much? Someone in the audience might say, but that is hereditary thrombophilia. How about antiphospholipid antibodies? Antiphospholipid and antiphospholipid antibodies do not interfere with pregnancy, do not lead to lower pregnancy rate. And you can go into the literature. There is a systematic review published 22 years ago by a guy called Hornstein, where it shows in very large studies comparing prospectively antiphospholipid antibodies positive and antiphospholipid negative. If anything, actually, by chance, the positive one had higher live births, not pregnancy or clinical, higher live births, which means it is not. When we measure it, it means that we are confused and we can't make distinction between IVF and recurrent miscarriage. Antiphospholipid syndrome is only a syndrome if you have the antibodies and the miscarriages. But if you have the antibodies alone, it does not diagnose anything. And you should ask yourself, why did you get the patient to pay money for the test that doesn't make any difference to the next step? And the list goes on. And occasionally we have a new kid on the block, like the microbiome. If you read the literature, you will feel like crying. There is a paper in American Journal of Obstetrics and Gynecology that's reporting 60% live birth rate in patients, the average age of whom is 40, simply because they have the right microbiome. So the right microbiome كان المسيح الحي. It eliminated anything to do with aneuploidy. It eliminated anything about endometrial receptivity, and it was enough to have the microbiome. The literature does not need expert, does just need someone with context and with common sense. Vitamin D, it became also a very much of a vogue, as if suddenly the sun decided never to appear again, and we all run out of vitamin D. If a patient has vitamin D deficiency, you treat her for her general health, but it has no impact on pregnancy or otherwise. When we use add-on, it means that we don't give common sense a chance. Because so many times I said, if you have a triple line endometrium and you can measure 9 millimeter on day 11 or day 12 of the cycle, what would the additional hysteroscopy give you? Other than the patient spending money like pouring them down the drain unnecessarily. So we do not use common sense, unfortunately. In actual fact, the way IVF is practiced means that we have decided to wish common sense to rest in peace because it's dead. Because when we prescribe all this add-on to someone whose problem is aneuploidy and old age, it means that we have done away with common sense. I grant it that we all have good intentions. We would like to do the best we feel or believe for our patient. But good intentions are not substitute or excuse for poor understanding. Because if we understand the fundamental, our intentions will be always focused on what adds value, not what adds to the cost of IVF. And our misconceptions. There are people who still believe that adding or giving, say, for instance, DHA will improve the live birth rate. It doesn't. The patient will have a mustache before anything happens. Yeah? It also says when we use add-on that we are willing and ready to believe unsupported claims. That is just music to our ears. When someone says this works, fine, give it to us because we will sell it and we will make money. That is the truth, because I can't find any other explanation. And there are plenty of claims, and some of them have been found wanting, and some of them still in circulation. And if we did that, we are complicit in or victim of aggressive marketing, because we have seen something marketed so highly, and people say, I have high pregnancy rate because I use this and this and that. You go and follow it blindly. That's not how medicine should be practiced. And that aggressive marketing is the hallmark of what is happening now. And I'm not talking about Egypt, everywhere, including the center of London. You see here the Daily Mail talking about a couple who spent £20,000 on IVF treatment before shelling out another £7,000 on add-on to boost their chances of a baby. They ended up suing the clinic. They took the clinic to court because they felt they have had their money wasted without any evidence, and these add-ons were worthless and unproven extra. Patients will go to clinic expecting fertility miracles because we tell them we can make our grandmothers pregnant sometimes in our claims, but it is fake news more than anything else, and understanding which IVF add-ons really work can be challenging. This is Sally Cheshire, who I had the privilege of working with her when she was chair of the HFA. She's talking about particularly older women being exploited by IVF clinics because she looked at the data of the HFA and found that there is a handful of success for patients age 44 because biology, unfortunately, is not on their side. We also pay little attention to the evidence in support of these add-ons, or we are unable to judge what is good evidence from what is bad. And that is true, and that's proven. The majority of clinicians who feel confident in doing this will fail the test. So some of us are unconsciously incompetent, which is the beginning of the competence step. When you look at the HFA website, always talk about treatment add-ons, and the fact that their evidence is not there. They describe them as these are optional extra that are offered on top of standard fertility treatment, often at an additional cost. So money comes in. Emerging techniques that may have shown some promising result in initial studies, or they may have been around, but have not necessarily been proven to improve pregnancy or birth rate. And some clinics will have extra charges for this, of course, otherwise they won't be selling them. And we devised this bit of traffic light rating, and it is qualified. When we have more than one high-quality randomized control trial, we give that intervention green. Can anyone tell me of any add-on that in their knowledge can qualify to have green traffic light? None. So if that is as frank as this, how can we justify getting the patient to pay? Orange or amber, when there is conflicting evidence from some RCTs, but they didn't have the word robust and they have conflicting evidence. If you don't have strong evidence and if there is conflicting, why should the patient pay? And red, when there is no evidence, there is RCT and so it does make no difference. And here is some of the add-ons, whether it's assisted hatching, with taking red, and endometrial scratching at the time was orange, but now it's deep red because we have repeated good randomized studies to show that it doesn't work. And immunological test and treatment for fertility is red. Using MC is red. Using intrauterine culture or PIXI plates to select the mature chromatid is red. Pre-implantation genetic screening for aneuploidy is red, and so on and so forth. And the others that are not red, not because they are good, because there hasn't been the evidence to get to that conclusion. We always forget that the hierarchy of studies start and begin with randomized controlled trials that are done properly, not half-baked, not with a number of convenience, not a single center, not with prior intellectual prejudice or commercial one, no, proper randomized controlled trial, and everything else comes after. The only way to be confident that a treatment is effective enough to be used routinely is to carry a randomized controlled trial that is of sufficient power. And contrary to that, when we approach add-ons, we believe in our observation. I use it that it works. How many times when you're having dinner and speaking to someone who said, oh, I use this, and in my experience, really, it gives me good result. What does this mean? What good result mean? You are making observation that's already biased and can be challenged, and it's not objective. It's just your conscious or subconscious. And rather than having the normal hierarchy of evidence, where randomized controlled trial at the top and expert opinion at the bottom, some people decide to turn that pyramid, and they put their expert opinion at the top. It's not good enough, I'm afraid. It is not good enough. No matter how good you are and how expert you are, you will get it wrong. And then, when do we not need RCTs? Because some people get so irritated and say, you're always talking about RCT. Is RCT be all and all? Do we need to do RCT for everything? Of course, the answer is not. You don't need to do RCT if you have something like this. Like Bob Edward was reporting in that very small letter to the Lancet, something that changed the world, that won Nobel Prize, that is still with us and making millions of babies. You don't need that, because if you didn't do IVF for a patient with bilaterally blocked or removed tubes, nothing will happen. But if you give her IVF, there will be 14% chance at the time to leave the clinic with a baby. So you don't need a randomized controlled trial for something like this, the so-called signal-noise ratio. There is a clear difference between treatment and no treatment. But you need it when you are dealing with something that's so tenuous that you can't discern. That is what I told you. I'm about to finish. It means also when we prescribe add-ons that we have not learned a lot from previous false claims and mistakes. I might give you one or two examples. One of them is endometrial scratching. People were doing it on everybody. Why? Because initial study that was not randomized showed when you do scratching, you double the pregnancy rate. If you believe that anything doubles the pregnancy rate, you are in the wrong business. But when the trials were done, because you subscribe to, if it's too good to be true, it probably is, look at what happened. First study was from Hong Kong, registered, sample size was good, inclusions were good, and the assessment and analysis and the endpoint was ongoing pregnancy rate, injury 27, no injury 32%, no significant difference. Okay? And then we did our trial, 5 countries, major centers, registered before, 1,300 patients, 1,300 patients included, and the result identical. Live births 26.1 for the scratch and 26.1 for the no scratch. Then we move away, or at least we are expected. Then another study was repeated, good randomized multi-center trial, confirmed the same. So it's not the endometrium that we need to scratch, it's our heads. Are we doing our patient a favor really by making them spend their money? And this calculation is simple. If what the patient will spend on add-on will give her the chance of undergoing another cycle, be my guest. But if it will not give her the chance of another cycle, you might as well use the money to give her another try. That is proven and confirmed and everything else. Okay? And we're also victims of the medical literature, because the medical literature does not help. Everything goes. And it is being categorized here. You might like to read this paper, I liked a lot, that much of the published medical research is not reliable, or its reliability is uncertain. So to read a paper and run wild is not a good idea. Most healthcare professionals are not aware of this problem. As long as the paper is published in fertility, sterility, or human reproduction, then you take it as gospel. It is not. There is a lot of rubbish being published in fertility, sterility, and in human reproduction and other journals. They also lack skills necessary to evaluate the reliability and usefulness of medical evidence. Patients and families frequently lack knowledge, but the patient comes asking you to do the test and to give her that treatment. And you decide to give her what you want, which is not really good practice. And also we have Google, because if you look hard enough in Google, you will always find evidence for what you use. But that's convenience, it's not scientific. And this is something as basic as this. We always, at every level, believe you me, whether it is in Europe or in Africa or in Egypt, this bit can confuse people. They will always say, this finding is associated with reduced pregnancy rate. It does not mean that this finding has caused the low pregnancy rate. It could be just coincidence. And we go wild with this and put 2 and 2 together and we make 49. And lots of more claims about aneuploidy, and if you do PGS, it will make things absolutely wonderful. It didn't do. Otherwise, we will not be debating PGS 30 years from its introduction. If it was settled, we would be happy and we have moved on, but it isn't. And look at the literature. When it was first introduced, it says it has improved implantation. Outstanding contribution, positive outcome after pre-implantation genetic diagnosis. And few years later, it was shown that to be harmful. Patients who underwent this kind of technology, they have low chances of live birth, and so on and so forth. And when you see adverts, they are compelling because of commercial exploitation. Oh, you need to do PGTA for maternal age over 34, or even when the man is older, do PGTA. And when there is unexplained infertility and at any age, do PGTA. Prior failed IVF without explanation, as if you were expecting an IVF cycle to lead to a baby, and so on and so forth. It's really important to view what we see with a little bit more observation. Those who lack this skill will think of anyone who is critically appraising the literature as cynical. It's not cynicism. It is just paying attention to what we read. And currently, we talk about combining genetics and technology to double the success rate. Again, nothing will double the pregnancy rate. Whether it's genetics or whatever intervention will never double the pregnancy rate, because if it's too good to be true, it probably is. And C, that success has more to do with biology than with technology, and that will not change anytime soon. And we are giving ourselves bad name by having this racket of add-ons, and success has more to do with biology than add-ons, as I explained to you. And I honestly like to be challenged by any add-on that people feel on good grounds that it makes a difference. What next? If we don't invest in critical thinking and learn how to do it, we will always be fooled, and we will be fooling our patient of being followers. We follow what others do. Thank you very much.
Thank you very much, Professor Yakoub, for a very nice presentation. I hope you were convinced. Otherwise, who has a question?
Sorry? This is only exists in your vocabulary. I have been practicing IVF. It never occurred to me to test for it. Yeah. Yeah. Thank you. Thank you.
It was the truth which you told us.
Thank you.
And as the past chairman of ASHA, I will propose this lecture as a plenary lecture at the opening.
Thank you very much. I appreciate it.
We have this ethical duty.
Yeah.
Thank you very much.
Thank you. Well,
Yes, but please.
Thank you, Professor Yakoub. Just a question about the HFEA traffic lights. Since we have, green, orange, and red, why we don't stop it? Why we don't stop people practicing it?
it
Why
is
it's
not.
illegal?
Yes, it is. Everything has to be lawful in the UK. The HFA is not mandated to stop clinic for offering these. Their mandate is to make sure that they look after using embryos, storing embryos, using embryos for research properly. Everything else is add-on. So they are doing volunteering. We have volunteered to just advise practitioners so that they know what is right and what is wrong. But you cannot enforce it. What we had to do, I've been chair of the Scientific Advisory Committee for about 7 years, we had tried to do it the other way. We got hold of something called the Marketing Competition and Marketing Authority. And we asked them to force the clinic to have a transparent list of the price. So the patient can have informed choice. If they put any add-on, they have to show the evidence next to it. Otherwise, they will be accountable to other authority whose job to make sure that advertising and claims are verified and checked. And the first report was produced on the 23rd of September this year.
Actually, I have to congratulate you every time. Actually, I listen to your comments about that, and I actually congratulate you about that. Common sense is not becoming common at all. This is a real problem actually in the medical field. And the other thing actually that's appealing as well in the management of cancer as well is people now are talking about the economic toxicity and the moral toxicity, where you actually give hopes to patients, you drain the resources actually with treatments either which have trivial or actually have no apparent effect at all. And this actually is, as you mentioned, has a great ethical and professional problem. Thank you again.
Agree. Thank you.
Salah, last question, please.
Thank you, Professor Yakoub.
My pleasure.
Very interesting and very actually important to avoid excess money on the patient. One of these add-ons, you said measurement of progesterone the day before.
The day of HCG.
Yes.
Yeah.
I am asking your opinion about the measurement of progesterone before embryo transfer in thawed embryos.
Right.
Do you measure it?
I don't do either. And I tell you why. It has already been demonstrated, but also there is vogues and there are papers and there are chairs and all of that happens as a result of many publications. If you measure progesterone at the level that you look to see on the day of HCG at 8 o'clock and at 10 o'clock and at 12 o'clock and at 2 o'clock, the patient will be zigzagging between normal and abnormal in the same day. And the variation at this level is so significant, that's not me saying, people who know a thing or two about biochemistry and progesterone. That's one. The second one, the decision that we make based on those results have never been validated. There is no study to assess the harm and the benefit from freezing just because progesterone was high. Would the harm from freezing for a patient who has 3 embryos be more, or the benefit will be more of this? Nobody has done it and nobody asking about it because we like to go with the flow. That's one. The second one is fundamentally, I will never agree with a cutoff figure for biology. Biology only knows ranges, but it doesn't know a single figure. So to use a figure to be determinant whether you do something or another is fraught with really difficulty and controversy. I stand here, I only talk about what I practice.
Thank you very much.
Pleasure.
Professor Khalaf.
Thank you.